Very good morning, and I think today when the whole country is celebrating Republic Day, and in the same way they are also enjoying the holiday, but this bunch of the people, I think we are working here, and is working for the cause of attaining knowledge sharing. So unusual, of course, that they always organize on 26th January. So, but still, I think there's absolutely pride in taking that. We, for us, Republic Day also is not only working day, but it is a day which do not do the routine work, but we do out of the way. We go out and share our knowledge. Now, this topic, that quality, care, and marketing. Healthcare actually has been evolving, of course. But I will say past 5-6 years, I think this evolution actually is taking a different level. And there's a huge discussion that so far governments have never bothered about healthcare, but that also is now changing. And suddenly we find that governments are taking, of course, interest, but whether that interest is in the right direction or what way it will take us, we are yet to see that. But at least there has been interest now in the healthcare. When we talk of quality in healthcare, I think, of course, it is a recent phenomena as far as India is concerned. In fact, I was giving a talk day before yesterday at the ISRO conference, where delegates from France, Japan, US, Korea, they had come, and they wanted actually somebody to speak to them on the quality journey in India. So by virtue of being the Secretary General, earlier Quality Council of India, ISRO invited me. It was very interesting because I don't think I had given that kind of talk, but I have guided 2 PhDs on this similar subject. So, I was able to put across in 45 minutes, and I was able to really get surprised myself that formally Indians have not worked in the field of quality till 1950s. Till 1950s, we were mostly, quality means it used to come by traditions, in handicrafts, in music. So we were known of quality producer in those areas, not in industry, and of course forget about healthcare, And then after seeing the research work, I was able to find that the earliest quality initiative we were talking in this country was in 1954, when BARC was set up. Because BARC cannot work without quality, and that is where the formal subject of quality got introduced in the country. But it remained within the 4 walls of BARC, And then gradually, if you see, you must give credit to maybe our Jawaharlal Nehru, who brought PSUs. Because most of us think that quality normally comes from the private sector. But actually in the industry, the quality was taught to India by, let us say, organizations like HAL, BHEL, and 1969 the turnaround took place when ISRO came. The ISRO actually raised the level of quality, obviously, to the very high level, but again that remained within the 4 walls of the ISRO. And then actually if you read, it is interesting for some of you, that's why I am spending 4 or 5 minutes on this topic, that actually it kept on doing, the PSUs were made to work on quality, what you call today Navratna. And you must give credit to the organization like Steel Authority of India, Bharat Heavy Electrical, Bharat Electronics Limited, NTPC. Actually, they are competing with the best of the multinationals like Siemens, Philips, and other companies. They are really competing. So the quality actually brought in the country by these PSUs. And then the final push came only in 1982, when the Japanese gurus, starting with Ishikawa, they visited India and At that time, then the CII, FICCI, ASSOCHAM, they set up the TQM cell in their organization. And then, of course, the quality really took a big jump. So the question is that quality is not very old as far as we are concerned. It is very recent phenomena. Now, when I said 1982, quality journey in the private private sector, 1982 is also important because from the healthcare point of view. Because Dr. Pratap Reddy, which I always name him, that he became a person who could take courage and bring out and establish that small way the Apollo chain of hospitals, because that was the beginning of the corporate entry into the healthcare. And till that time, there was really hardly some 10 to 12% of presence of the private sector was in the healthcare. And healthcare was largely being delivered either by the government or by some of the trust hospitals, you know. And looking at the shortage, looking at the reluctance from the government to expand the public health base, I think the initiative of Dr. Pratap Reddy should be always remembered. Of course, later on, of course, we have got now many players, and today the situation is that 80% of the OPD services are being delivered by the private sector, and 60% of the IPD services are being delivered also by the private sector. So private sector is a big player, and we also, I must tell you that even in terms of the financial contribution, that 3.6% is coming from the private, 3.6% of the GDP is coming from the private health sector, and 1.3 around is coming from the government sector. So put together, we are roughly 5%. And 5% of the spending of the GDP as compared to 9.8, which is the global average, is obviously way below. But still 5% can do wonders. And that is where the discussion we are presently having with the government of India, that Thailand with the 5% of spending is able to provide universal health coverage to its citizens. Why can't we? If we raise even just 1 more percent, 6%, but the problem is that 3.6 and 1.3, they are not working in synergy. So the public sector is working independently, private sector is working independently, and that is where we have not been able to create the impact, what we call it, what it should come from the universal health coverage. So this is where we stand today, and I can only say that what discussion we are already having with the government for past more than 2 months. You may get some good news in the 1st February in the budget, that we may get some aggressive initiative from the government in terms of health coverage to the entire population. Let us see what comes, because sometimes what discussion we do in Niti Aayog and in the government, when it actually comes out, the government is, you know, here throws surprises. It may exceed or it may go other way around. So, but anyway, something is going to happen, some good news is going to happen on 1st January. So now with this little background, the quality, let us say, yeah, actually when I was talking about quality in a country journey, so as far as healthcare is concerned, you must understand that quality in any field is always driven. Quality doesn't come of its own. I mean, this is fundamental. Now there are 3-4 factors by which you can drive the quality. The best way of driving quality is that it should be consumer driven, you know. Now in the people, because all of you are from the healthcare here, in healthcare there is a very popular subject nowadays, you know, the patient-centric hospital. That means the hospital, whatever it does, the first focus is not finance or not anything else, but first focus is, are we, whatever we are doing, is it centered around the patient? But recently, not recently, about 7 years back, there was an international conference in USA where they are now, there was a big debate and they are talking about not patient-centric but patient-driven hospital now. So that means they are going a notch above. that the patient will be the key factor who will be driving even the care plan for himself or herself, you know. So this actually word, from patient-centric, we are going to being patient-driven. Now, where are we in India? Obviously, we are not. Of course, a lot of effort is required to become patient-centric. We have problem in India is that we have excellent healthcare delivery in cities like Bangalore, Hyderabad, Chennai, Mumbai, Calcutta, and things like that, where actually, as per our own survey, which was done about 2 years back, we found that most of these cities, we have got 30% extra bed capacity. But we keep complaining that there is a shortage. There is no shortage as far as these 9 cities where we did the survey. We found on the average 30% beds are always available. You know, you may say one hospital is full 100%, another is only 40%, but average 30%. But the question is that then there are majority of the areas we do not have any healthcare facility. So I think the distribution, which has been so badly done, and there are other reasons which actually in this lecture I will not go, why actually it has happened. So the question is that getting quality, if you want to drive quality through the consumer, then you must create the competitive environment. If you do not create the competitive environment, there is no competition. You are at the mercy of that one healthcare providers in that area, you have no other option. So we in this country cannot be a country where the patients or the consumers can drive the quality in the healthcare. What is the second option? Second option, which is by regulation, that government puts in, bring its regulation, that the healthcare people should be able to give you that level of the care, that level of the patient safety, and also go one step ahead and fixing the price. That is actually. So what actually government is doing nowadays, little bit, they are not fixing the quality, they are not fixing the patient safety, they are only fixing the price, you know. I mean, so this is very sad way of doing it, that you only fix the price and without deciding the specification or the care level. But anyway, I think they will also learn, and because sometimes you are driven by the populism, you are driven by the playing to the gallery, so that is what governments keep doing it. So the quality in healthcare is still a long way to go. Luckily for us, the quality framework was defined in this country through NABH, and that also happened by accident because there was a demand on medical tourism, and then the government wanted somebody to establish the NABH and the Quality Council of India. We did the job, and today we have got at least a good framework available in the country by which quality is actually defined. And why quality is defined? Because quality in healthcare is nothing about what you normally talk of quality in a, let us say, hotel, or what you talk quality in the automobile, or what you talk quality in any other. Quality in healthcare, luckily I will say, was defined world over. I will say again the cutoff date is 1951. 1951, when the College of Surgeons in USA, they came out. I don't want to go into history before 1951, but 51 was the actual year where they could establish the Joint Commission, and then Joint Commission became the face of quality world over, you know, that this is the way quality is defined. And the good point was, because it came from College of Surgeons, so it was right from word go, it was the clinical quality, quality for clinical outcomes. Managerial aspect was only kept as a framework, but the focus was on the patient safety. And that is where the quality of healthcare is different. About a month back, we were in Taiwan, and there was an international conference, IHF, and in one of the panel, I mean the people, you know, very briefly I will tell you, one of the gentlemen was asked about that, okay, if you visit a hospital, how can you compare hospital with any other industry? So he says, I can compare hospital obviously with the automobile repair shop. It is a repair shop, people come for ailments, they get repaired, and once the repair is done, they go back. Some people come for the annual maintenance, the way we send the vehicle for annual maintenance. So I said, I see hospital as a automobile garage, Okay, good. Second gentleman, I remember the second gentleman was from Vietnam. He said, I see the hospital as a hotel. People are put up, either it is an emergency or it is in the beds, they are very comfortably put there. They get every treatment done there, and hospitality is best of the class. So it is nothing like it is like a hotel. Third gentleman said, oh no, I find that hospital is like a jail. Once the person comes here, he can't go out, he cannot eat food of his choice, working hour, visiting hour, so everything is like a jail. So now I don't want to go a little more than what other people said, but in the crux you see the hospital is very complex. And let me come to this point very frankly to all of you, that I was giving talk, let us say in ISRO, which is the most complicated thing we consider, that sending the spacecraft to the space. But hospital is not less than the ISRO. The kind of complications which are there, each patient with the same disease actually will have different complication, multiple complication, combination, morbidity, comorbidity, the kind of things which we happen are really different. So today, hospital business has become a very complex phenomena. So talking of quality in such a complex thing is obviously going to be a tough job. Now, because in the definition you saw that quality in healthcare is the second name of patient safety. So we do not talk of quality in healthcare by virtue of that your hospital has granite or marble or top of the line registration staff, good ambience. That is one aspect. Actually that only facilitates, but actual quality comes by what kind of clinical outcomes you are delivering. And that is where my little talk for next 10 minutes will be on, that quality, if you want that superior quality what you are saying for the patient care, will only come when we are able to educate to our doctors and to all the staff that what actually is the quality meaning. Why I am saying so? Because today, all of us in the healthcare, we may have super specialty degree in one of the specialty, but in fact we are not even aware what kind of medical errors occur while working. Because nobody intentionally does any error, but there are systematic errors which keep on happening, and that actually is the point of worry. And the study which I sometimes keep quoting, that 5.2 million medical errors were reported in India based on the Harvard study, is point of a serious concern. So in fact that is where the point is that this is the way quality actually we are defining, that all of you must focus that quality, or what you call accreditation, is nothing but the patient safety. That is on the center. Now who is responsible for the patient safety? The patient safety responsibility is obviously with the physician and the surgeon. We keep confusing that most of the hospital when I go, that who is the coordinator of the quality or who is the accreditation coordinator. I find invariably a administrator, somewhere now they are pointing the nurse leader as the quality coordinator. So I think sometimes I get an impression that quality responsibility has been either given or been taken over more by the administrator, while it should have been taken by one of the top surgeon or top physician in the hospital, which actually unfortunately has not happened much. But hopefully I think that certain things are happening. The second level of course is the nursing staff, then we have got the diagnostic services and the logistic management, and that of course we come to the accreditation. So what I am trying to tell you is that when you use the word accreditation, accreditation actually is encompassing everything, but focus still remains the patient safety. So this point must be understood very seriously, that if you want to evolve the quality, if your hospital clinicians have taken the ownership about the quality, you are going to achieve quality, but otherwise I think this will remain more of a superfluous job rather than getting the real outcomes. So finally, I am trying to tell you here that the healthcare industry today being the complex, it is very important that we work as a team. Now, this issue, when I am saying it, work as a team, because the doctors, consultants, residents, nurses, paramedic staff, I find many times they work in their silos. We have paramedics people, we have nursing staff, we have got junior resident, we have got senior resident, we have got consultant. They work in their own spheres, so that actually they do not work like a team. And because the healthcare will continue to remain under regulation for valid reason, sometimes for the non-valid reason. Valid reason, of course, is that it is an area which affects the well-being of the citizens of the country, so it has to be regulated. But other reason is when the political consideration wants to drive the healthcare, then the regulation may take the little wrong turn. Now, question is that technology, which will be the main subject in this conference, because technology has come in a big way now. Now we keep complaining, rightly so, that the skill of the modern generation doctors is going down. The reasons are many, but one of the reasons is that because the doctor has availability of the technology, he or she will like to use the technology to do the correct diagnosis, and gradually when you start depending on the technology, your own skill, human skill, obviously will take the back seat. And today, because technology has advanced so much, and in next 5 years I can tell you it will have mind-boggling effect. Now about 2 years back, when we saw the demonstration of the clinician decision support system, and the kind of disease pattern they were showing to us, it was really very surprising that for doctor it becomes so easy now that he puts the symptoms of the current patient who is he is examining and puts it on the computer. Immediately you get the nearest proven diagnosis done earlier, what medicines were used, what treatment plan was used, actually it comes in front of you. So the job becomes very easy and of course accurate. But obviously the negative side is that it obviously adds to the cost, because technology at this point of time obviously has the cost. Of course, again there will be time after 5 years that this current technology will become so cheap, when actually more development will take place, more volume will come. So, but anyway, I think the question is that because of that, now the family has got huge expectation, and that is where we keep getting the cases of violence. That if there is a death of any patient, I mean, people have been dying in the hospital, where is nothing new. But today, if the patient dies in a hospital, that becomes the news. That how the hell patient death has occurred in a hospital. So this is a question. Now, for that now, the doctor community have to undertake the different role. They have so far not taken the leadership role. So that is where my current advice is now, that doctors now require a new skill, new set of skills. One of the simplest is the communication, that actually is lacking. So this, what we are now promoting in most of the hospital is that the clinician must act as a leader. We must have a number of the CMEs for the clinicians. The simplest one is the standard treatment guidelines. Unless we have not been able to promote the standard treatment guidelines, because most of the clinicians, they do not want to undergo the simple program on the standard treatment guideline, because they say we have been practicing, we don't need training on the standard STGs. Now, clinical risk assessment is going to be the subject which actually will be now enforced by all insurance companies. So far we don't use the word clinical risk assessment. We can do earthquake, fire risk assessment, but nobody actually talks about the clinical risk assessment. So this is a topic now which actually is being pushed forward mostly by the payers, and that will become the talk of the town. And patient-centeredness, I already told you. So the clinical audit is the area, or clinical governance, which is the area which actually is a very old subject, but actually it has hardly been discussed in our country. So the clinical governance, and within the clinical governance, clinical audit. That means each specialty will carry out an audit, and for which we have, I'll give you first the structure here. For example, here, we are now recommending this model. This is a completely new model for the Indian healthcare sector, where we are suggesting that each specialty head will call a operational excellence meeting, and in this meeting we will be focusing on clinical and non-clinical departments associated with that specialty, for example, anesthetics, pharmacy, information technology, quality, facility management. All these people will gather around with all the surgeons and physicians of that particular department at least once in 2 weeks, at least. And that means all the cases which have undergone in past 2 weeks, they will be openly discussing what were those cases, what were the outcomes, where we went wrong, what could have been done better. And these, which we have launched in very few select hospitals, has already started bringing excellent results. So the subject of quality which you wanted me to cover, today I link more with this kind of quality rather than the managerial quality. So I think this is the area, and where they also, of course, they discuss that how we could have done that particular procedure better, how we could have brought down the cost. Because so far, doctors are never trained on efficiency. Doctors are trained on how do we do a good job. That, of course, is right. But how do we do it so that the cost also becomes minimum? And so that aspect, doctors are never trained. And because we have got the excellent administrator now around them, they take care of the job. But that is okay. Holistic cost component, the administrator will take care. But for that process also in OT or in the ward, how the doctors can do the process or procedure in a way that it becomes cost effective. So this is what actually is the topic, in this agenda of the meeting which we have kept. These are the agendas, which we utilize during this operational excellence meeting. And because this is a very set agenda, you have to deliberate on all these things, and this, let me tell you that even with the top of the line corporate hospitals, we do not do it because each operational head has got no time. I mean, they keep on performing the procedure or surgeries, and you can't expect them to sit half a day only for debating this. I think they will laugh at you first, But we are actually forcing some of the hospitals to do it. Let them do it on Sundays. If you can come on 26th January, they can also work on Sunday for half a day. Anyway, I think the question is not Sunday. Any day they can sit, there is time available. So this is the, way quality will be driven. And the takeaway points, actually, which I am going to put in front of you is that role of physician is going to be the key in driving patient safety / quality of care. Sooner we do, better it is. So this culture of depending on the quality manager who is not really a clinician or on the nursing leader actually has to go away. Put the clinician in the forefront. Make him the responsible. You are the NABH coordinator. Administrator is there to facilitate the role. The administrator cannot take the responsibility of quality on himself or herself. Physician has to be trained on undertaking clinical audit. And when I am saying clinical audit, let me tell you very frankly, those people who are here, clinicians sitting here, they know it that they are not trained on clinical audit. They are not trained on patient safety. Even in the WHO has brought the patient safety curriculum not now, 20 years back. And that is an excellent document available on the patient safety developed by the WHO, but we have not introduced that in the medical colleges. So something of that sort, we teach a surgeon at the age of 45 years or 50 years that this is the meaning of patient safety. I mean, that has to stop. So that's what we are trying to do here is, and regular operational excellence meeting to provide opportunity for physicians to do introspection and establish the teamwork with the members of nursing, quality, diagnostic, pharmacy and administration. So these are the points which will bring the excellence in quality. So today I have tried to give you a little different perspective of quality rather than what conventionally we talk about quality. So the focus, as I said, center stage is to be taken by the clinician, and once they take the center stage, other players automatically rally around the clinician. So this is what actually in the 30 minutes I could give you the simple message. I will be here, of course. We will have other aspect of the quality we can discuss during tea break or lunch break or thereafter. Thank you very much.